Now, when we look at the causes of heart failure, there are many, many, many of them, far more than we can talk about. But if we look at those situations where some unusual demand on the heart just can't meet it, they fall into a number of categories. And I will illustrate each of these in a moment. But one very important category is resistance to flow. In other words, if something is keeping the flow of blood from going, so the heart has to work harder to push it past that resistance, it will come to the point where the heart can no longer do it and it fails. Another problem is what we call regurgitant flow. I mean, you like to think of the blood flowing in one direction through the cardiovascular system, but sometimes it comes to pass where at a point there's regurgitation. Instead of things pulsing forward, they slosh backward, and that imposes a strain on the heart, as you will see. And thirdly, and very importantly, there's disease of various sorts, lots of sorts, targeting the myocardium itself, so that there's no resistance to flow, there's no regurgitant flow, perhaps, but the heart muscle is sick. And then finally, and we won't talk at all about this, I won't today, is conduction abnormalities, which can also lead to decompensation of the heart. Now, I'd like to illustrate some of these very quickly. Don't get lost in the details. Just let it flow over you. You're going to get these details later on in the year, later on in your careers, but just for a little orientation. Give you examples first of resistance to flow. And there is a good hallmark for it. I can't show you hypertension, obviously. But think of a situation when a patient has established significant hypertension, and it means that 24/7, with every minute, every beat of the heart, that poor left ventricle is having to force against an increased resistance to flow. That's what hypertension is all about. The result, one of the results you see here is this rather massive myocardial hypertrophy, which I'm sure you all recognize. So that's one kind of resistance to flow. Here's another one. This takes a little explaining. It's an unusual plane of section of the heart, but what attracts your attention right away is that left ventricle is immensely hypertrophied, very thickened, very heavy. And the reason for it is not terribly well shown here, but here's the aortic outflow. This is the aorta here, and this would be the aortic valve here, which you can't get a good view of. But a common lesion is stenosis of the aortic valve. And obviously, in that situation, it's much analogous to hypertension. Every time the ventricle contracts, it's got to push that blood through a stenotic valve, and it's a lot of work. I'll show you one of these valves from above. This is an interesting one. This is a pretty typical example of aortic stenosis. You're standing in the ascending aorta, looking back towards the left ventricle, and you're aware from your gross anatomy that this should be a three-cusp valve. And you're seeing a couple of things here. First of all, this is only two cusps. And that was a congenital problem, and it's a fairly frequent one in our population. There are probably a couple of so-called bicuspid valves in this room. And whatever the case, the aortic valve is very susceptible to calcification and stiffening with age. And if you plot it against the aging population, we're seeing an increasing incidence of stenotic aortic valves, even if they're not bicuspid. If they're congenitally bicuspid like this, they get wrecked very frequently earlier on, so that instead of maybe in the 70s or 80s, it might be in the 50s and 60s that the patient would suffer from such stenosis. But you can see that every time the ventricle is trying to push blood through that orifice, and it's really like brick, doesn't move, it's going to be a tremendous load on the left ventricle. Here's another valve stenosis for you. We don't see this as much anymore. It's the result usually of an old rheumatic fever in childhood. But the mitral valve here is reduced to a fish mouth, literally. It's all puckered up and scarred and frequently calcified, and the valve leaflets can't move at all. So then the blood coming out of the lungs into the left atrium, trying to get through into the left ventricle. You're looking down towards the left ventricle. It's got to pass by that stenotic slit. The result is damming back. Very obviously, you know about passive congestion now. You can see this immensely dilated left atrium, and you can imagine what was happening in the lungs behind that sort of obstruction. Now, as far as regurgitant flow, hold on with me and I'll try to explain it. Here is another mitral valve. We've chopped off the atrium, and you're looking right at the mitral valve. And think about what you saw in Gross. The mitral valve leaflets usually come together like that and keep the blood, during systole, keep the blood from flowing back into the atrium. So all the blood goes out the aorta, like it should. Here, and this happens for a variety of reasons, but here this leaflet of the valve is sort of pooched up, and with every ventricular systole, blood is able to force its way back into the atrium, which means the poor old left ventricle is pumping some of that blood more than once. In other words, it's putting part of it out the aorta, part of it back up to the atrium, and that comes sloshing down for the next beat of the heart, and it induces a volume overload on the valve and or on the ventricle, and it may fail. Now, when you get to the realm of myocardial abnormality per se, in other words, disease of the myocardium, there are lots and lots of examples, and the most frequent one, the most important one, is myocardial ischemic disease. In other words, the result of coronary artery disease, of atherosclerosis and its complications, and what happens when the myocardium becomes ischemic. And clearly, many patients who have a myocardial infarct, an acute heart attack, will go into acute failure if enough of the myocardium is involved right then and there in the emergency room. But chronically, it can become a big problem even when the situation heals. Here, for an example, a slice of a heart. This is left ventricle over here. And this individual sustained a myocardial infarct, I don't know how long ago. It could be years ago, months ago. And you see a lot of scar throughout the ventricular wall, a little bit back there, a little bit in the septum, but a tremendous scar here. And when this involves enough of the ventricular myocardium, it puts a strain on what's left of viable myocardium, because this obviously doesn't contract. And patients can sustain a lot of myocardial infarcts. Here's serial sections of the same heart, and you can see at least a couple of infarcts that have involved a tremendous fraction of the left ventricle. And again, when that happens, the rest of this can't keep up with it, and the left ventricle fails. Here is a heart that was removed from a patient who's still alive, happy, and well, as far as I know. This is an explanted heart, in other words, taken out at the time of transplantation. And this was also ischemic disease. And this individual had scraped through with this much of the heart converted into what amounted to just a fibrous sac, totally non-contractile. And you can see there's even clot in there because that wasn't moving. And that had produced failure of the remaining myocardium. So that's a good sample of ischemic disease leading to chronic failure of the left ventricle. Now, beyond ischemic disease, there are a whole lot of them. Don't worry about the details. I'll show you this as an example of an inflammatory process targeted at the myocardium. We see this with certain viral infections. I've seen it with protozoan infections, with bacterial infections, but you can get inflammation of the myocardium. And you can almost literally hear these cells chewing at the myocytes. And obviously, that can produce failure. And we see that not infrequently. Then the heart can be involved in a variety of systemic diseases. In other words, you can have something going on affecting many tissues in the body, but that something may affect the heart and produce failure. Here's an example. Now, I don't know if I want to darken the auditorium completely to show you this. Did you discuss hemochromatosis and genetics? Yes? Not a complete blank. It's in effect a storage disease because the body absorbs too much iron from the gut. And the iron gets stored in a variety of tissues, and one of the tissues that gets stored in is the heart. And you recognize this instantly as myocardium, And as you stare at it a little bit, you'll pick out some nice golden brown pigment there and there and there and there and there. And you see a little bit more there, a little bit down there and over there and over there. And one of the pigments you'd think of in the heart, someone asked me a question about this last week, it would be lipofuscin, wear and tear pigment. But another pigment you got to think about is iron. And it turns out this is stored iron in this myocardium. Here is that blue, Prussian blue iron stain that I showed you. Tremendous iron load. Iron is bad for you if it gets deposited in certain tissues, and this can produce myocardial failure. This was from a relatively young man who presented with very advanced heart failure because of his unrecognized hemochromatosis. One other that you will hear about probably next year is amyloidosis. Amyloid is an abnormal protein that can get deposited in a number of tissues for a number of reasons, which I won't go into. But all of this sort of translucent gray stuff surrounding the myocytes, you're looking at a cross-sectional view of myocardium, and you can see that each myocyte is kind of enveloped in this casing of amyloid. And this is a marvelous example of something that renders the heart rigid and unable to expand diastolically and can be a cause of heart failure. Finally, and this is not a complete list, I'm just showing the examples, there are a number of genetic diseases of the heart muscle itself, where from the get-go, because of abnormal genetic endowment, the heart is made wrong. And here's an example of something we call hypertrophic cardiomyopathy. Cardiomyopathy means heart muscle disease. And this particular heart was immensely hypertrophic. You can see that left ventricle. It's really tremendous, with no valve disease, no hypertension to explain that. But look at the goofy muscle. You know what myocardium is supposed to look like, and the histology people never show you kind of disarray and crisscrossing of fibers like that. This is the result of a genetic abnormality of this myocardium. All right, these are just a few examples of the things that can go wrong. And most frequently, if I had to pick from this whole list, I'd say hypertension and ischemic disease are the big actors, at least in our population. Whatever the cause, as the heart is overburdened, there are certain compensatory mechanisms that kick in for a while. In other words, that enable the heart to keep up with the abnormal strain. And some of these you know about, you've heard about, I'm sure, about the Frank-Starling mechanism, where when the myocyte is stretched by increased filling pressure, it's stretched, it contracts then with greater vigor. In other words, it can put out more oomph if it starts from a slight stretch. The trouble with that mechanism is it fails. In other words, for a while it's adaptive. You get more and more oomph for each contraction, and then it peters out for a variety of reasons. A second compensation is hypertrophy. And you know about this. We talked about it last summer, I guess. It's a situation where the same number of muscle cells are there, but more sarcomeres are added, and the muscle cells enlarge, the whole tissue grossly enlarges, and there's more oomph. I mean, it's very definitely a compensatory mechanism. And a third compensation mechanism I've listed as activation of neurohumeral systems. And we're not going to go into that in much detail, just enough so you know that they are there. Now here's hypertrophy. Normal size myocytes you see over here, and each one is on the average just a little bit thicker than the normal. That's because of addition of sarcomeres, not much change in the number of cells, and you can imagine these cells having more oomph, like a weightlifter. Imagine that, like a weightlifter's arm. And this is maybe what we see. Now, grossly, there's an increase in the muscle, increase in the weight of the heart, and sometimes we see concentric hypertrophy, meaning the chamber is not enlarged, and it may even be a little smaller, and gross thickening of the walls. And it's concentric. We see that usually with pressure overload. With a volume overload, we may see what looks like no hypertrophy at all, except that's a lot more muscle than there is normally. It's just that it's dilated. That also happens in very advanced failure from any cause. You see this sort of eccentric picture. When it comes to the neurohumeral mechanisms, I'm just going to race through these now. There is, first of all of these things tend to be triggered by pressure and stretch receptors that are scattered through the heart, the aorta, the carotids, and the kidney even. There's such sensing. And when the cardiac output begins to drop, these receptors say, uh-oh, and they trigger a number of things. One of the things that's triggered is the central nervous system, the sympathetic nervous system, with release of norepinephrine. And this can produce a contractile boost for the heart. This can produce an increased heart rate. These things will help meet an abnormal load. And also, this will produce vasoconstriction peripherally. This is designed, evolved this way, presumably, to make sure that blood gets shunted to essential organs. So there's peripheral vasoconstriction, which increase, well, we'll talk about what the bad things it does. Vasopressin is released from the hypothalamus. That's also a vasoconstrictor. And we talked in class previously about the renin-angiotensin-aldosterone system. The kidney senses the decreased flow that's coming to it, secretes renin, which acts on angiotensinogen, which is a circulating protein, forms angiotensin 1, and then there's an angiotensin converting enzyme which takes it to angiotensin 2. That in turn stimulates the production in the adrenal of aldosterone. And the importance of all of this is, first of all, angiotensin 2 is also a vasoconstrictor. And between angiotensin 2 and aldosterone, there is sodium retention, sodium retention and water retention, and that has some important consequences. And I just listed, I don't have time to go into it, the natriuretic peptides secreted by the heart, which tend to counteract the renin-angiotensin-aldosterone system to some extent. Unfortunately, all of these mechanisms are limited in how much help they can provide, and there's a downside to a lot of them. Now, problems with hypertrophy. You might think hypertrophy is perfect. Just get bigger and bigger and bigger muscle. It doesn't work out that way because the capillary network in the muscle does not increase in parallel, and you end up with perfusion problems. So there's a limit to how much hypertrophy the tissue can stand. Same is true for the ratio between mitochondria and contractile proteins, so to speak. The mitochondria to meat ratio does not keep up to what it should be, so the energy is a problem. Then, very importantly, we're learning that there is altered gene expression and alteration in the proteins that are produced, and these may involve contractile proteins, the contraction coupling, they may involve energy utilization, but some abnormal proteins are made. There's an increase in apoptosis in a hypertrophic myocardium. And under the influence of all of this, it's actually driven by the various hormonal things that I've mentioned, and something we call remodeling occurs. There's a change in geometry of the ventricle, which can have implications. It tugs on the chordae tendineae of the mitral valve wrongly, and you get mitral regurgitation. It's a disadvantageous thing, often associated with a lot of fibrosis. That blue-green tissue racing through the myocardium is a fibrosis in a remodeled ventricle, which causes problems of its own, as you can imagine. I don't have to go into any detail. So that's a problem. And there's a problem with neurohumeral activation. Vasoconstriction increases the afterload that this poor old failing heart has to pump against. I mean, it sounds like a nice mechanism, but it bites the heart. Various of these humeral substances are cardiotoxic chronically. In other words, they're responsible for the increase in apoptosis. They drive the remodeling, and it's a bad thing for the heart in the long run. And we know about the implications of sodium and water retention and how that overloads the heart. All of these things contribute to the downward spiral. And I've simplified a very complex business, but there are many consequences for the peripheral tissues, and that's what we're really talking about when we talk about heart failure, is what's going on in the peripheral tissues. And these consequences we can talk about in a number of ways. We talk about sometimes forward failure and backward failure. Forward failure being the idea that the failing heart does not perfuse the tissues well enough. Backward failure, you're familiar with, the idea of passive congestion, and we talked about that in class, so you have a good image of that. And we speak of left heart failure and right heart failure. Most processes that cause heart failure start out on the left, but it's a closed plumbing system. So as the left heart fails, the right heart's going to fail. And the commonest cause of right heart failure, then, is left heart failure. There are some examples where the right heart fails primarily. It has to do with things happening in the lungs. They're relatively less common. You'll hear more about them some other time. But the backward consequences of left and right heart failure are very familiar to you already. We know that when the left heart fails, you get pulmonary congestion and edema. When the right heart fails, you get elevation of hydrostatic pressure in a variety of tissues with associated congestive changes in organs and accumulation of edema fluid. And this is when we start to speak of congestive heart failure. We throw in that adjective very, very frequently. What we've not emphasized, and I'll just conclude by mentioning this, are the forward changes associated with left heart failure. In other words, when the left heart fails, things begin to happen because tissues in a variety of places simply aren't being perfused. And you're familiar already with the activation of the renin, angiotensin, aldosterone system from forward failure to supply enough blood to the kidney. I would point out that as the perfusion drops more and more and more, the kidney can really shut down as far as its excretory function, and nitrogenous wastes can pile up. And sometimes people speak of a cardiorenal syndrome because of this. Well, many other tissues suffer from this lack of perfusion in the same way. We've shown you, for instance, the liver. And you remember the liver gets caught in a 1-2 punch. There's a resistance to outflow from the liver, and the fact is that the poor old failing left ventricle isn't delivering enough blood to this central lobular area, and it undergoes a sort of hemorrhagic necrosis, which you remember that. You never forget that kind of a picture. Now, something, a little wrinkle I'll simply point out here is that the aldosterone levels in patients in failure are way, way up there. And part of it, obviously, is because it's been triggered by the production of angiotensin II and so forth. But the liver, when it's in that kind of a state, does not catabolize aldosterone the way it should. And a patient may end up with 20-fold increase in the aldosterone level, partly because of synthesis and partly because of non-tearing down by the liver. One more example, the gut may suffer. In very advanced cardiac failure, patches of mucosa in the bowel may undergo necrosis because they're furthest from the blood supply. And we speak of ischemic colitis, a bit of a misnomer. It isn't an inflammatory condition, but actually that sort of thing can be a problem. Other organs, in fact, even the central nervous system, in very advanced failure, we see problems with CNS function.